morning, everyone.
Morning.
My name is Fred Durden. I'm here with Latoya Stevens and MK Obiora. Um, we want to try to take this time to answer any questions you might have or provide guidance for any open areas that we can. I am a reconstructive surgeon by second training. I'm an otolaryngologist by first training, which means I take care of cancers of the head and neck, and now I primarily take care of reconstructing defects or problems after someone has had surgery for a cancer. And so we'll start with the introduction and then try to get into um, other things.
Good morning, everyone.
Morning.
I am Latoya. I go by Benita Stevens. I'm an obstetrician gynecologist, board certified in OBGYN as well as obesity medicine. I spend the majority of my day doing general gynecology with a specialization in hormone management, particularly with perimenopause and menopausal patients. I also deliver babies occasionally, so I'm still in the hospital. But today, I'm here to just kind of give you some brief information about cervical cancer screening guidelines and just making sure you're aware of what you're actually getting when you go to your OBGYN.
And my name is Amek.
Yeah, mine. Get used to it.
Nice to meet everyone. So my name is Emeka Obiora. I'm a cancer surgeon, or in other words, a surgical oncologist. So my area of expertise is along the lines of managing pretty much all cancers of the gastrointestinal tract, and also things like skin and soft tissue, and also some parts of breast cancer as well. So my role pretty much involves the surgical aspect of cancer care, and we tend to do that as part of what we call a multidisciplinary team, which involves other providers, in some cases providers like Dr. Durding. So my role here today is to probably have a conversation and some highlights around what can be done for colon cancer screening and things to think about around the diagnosis of colon cancer.
Any questions? Do you have any question on extra family?
I think I have one. I have my father died from colon cancer at around the age 50, so I know I have a risk for cancer. Um, and I've had I guess because of that risk, I have to have my colonoscopy every other year, and the number of polyps is kind of increasing. Can you discuss how to reduce that risk, or is there a risk associated with the number of polyps?
Sure. So, in general, so let me give some general statistics to start out with. So, colon cancer affects about 1 out of 22 to 23 men and women over the course of their lifetime. And most colon cancers develop, so think about the colon as a tubular structure. So, that tubular structure has layers to it. So, there's the outside, there's the wall, and there's the inside. So, most all colon cancers, as we know it, originate from the inside lining of the tubular structure. Now, these polyps are of different variety. So you have polyps that are built like a stalk, like there's a stalk that originates from the inner lining and the part of the polyp that sits out, and then you have flat polyps. And then these polyps are then further classified based on their appearance. What do I mean? So polyps are basically abnormal growths, but not all abnormal growths are cancer. So the presence of an abnormal growth doesn't necessarily mean you have cancer, but these abnormal growths happen as a result of the nature of just how the colon is. So, but each polyp can evolve over the course of time. So, to reiterate, um, not all polyps are cancer, but pretty much all colon cancers develop from polyps, if that makes sense. So, not all polyps are cancer, but cancer in itself almost always exclusively develop from polyps. So part of what we do, knowing that information and knowing that colon cancer affects a significant amount of the population, that then becomes the tool of screening. So there are different tools for screening. So there's what we call a stool sample test, where basically you take the sample of a stool and then look in that stool sample to see if there's blood or DNA, which is basically genetic material that are associated with certain polyps or cancer cells. So that's one screening. So basically, what you're looking for is seeing if somebody has a risk factor, which is polyps. Now, there's also blood tests, which are less common that you could do as a screening tool. So, um, so there's a stool test, blood test, and then one of the last form of screening is basically an endoscopy test, what people call colonoscopy. Basically, it's a device where there's a camera, and then there are sort of other tools that are associated with the camera device that looks within the colon. So for that to be done, you need basically what's called a bowel prep. You take things that are laxative that cleans out the colon so that the colon is entirely empty, and then you can visualize the colon. So with visualization, you can see things like polyps that's different from just doing like a stool sample test or not. So to answer your question is that polyps can evolve and become cancer. If someone has a family history of a first degree relative meaning just one person removed, like in your case your father, or like in another case if it's your daughter or your son. So if you have a first degree relative that has a history of colon cancer, as compared to the general population, your risk is increased. So it's not always, but it's increased. In general, I would say a third of all people that have colon cancer before the age of 50, a third of those people, they will usually have some kind of familial thing. So it doesn't mean everybody, but if you get colon cancer, the thing to deduce from that is that if someone in your family has colon cancer early and they're a first degree relative, there's about 1 in 3 chance that something runs in the family. So usually if that's the case and you're at slightly higher risk, then it then becomes important that the screening for you is different from the general population that the risk is different for. So what do I mean? So the general recommendation is usually if you have a first degree relative that has a history of colon cancer, as compared to the general population, most people would say your screening should start at age 45. But if you have a first degree relative, most of the recommendation we usually say at age 40 or 10 years prior to the age that first degree relative had the cancer. So because of the reason I explained earlier, which is if someone that's a first degree relative has colon cancer, then your risk is higher. So again, going back to answer your question, again, colon cancer almost exclusively develops from polyps, but not all polyps are cancer. So colonoscopy, which is what I describe as one of the screening tools, what that does is that it identifies polyps, and there are tools by which you can remove those polyps, because we know that since all colon cancers almost exclusively come from polyps, then if you do screening and remove the polyps, then you can reduce your risk of developing colon cancer. Does that answer your question?
Yes.
Okay.
And I have one. When you remove the polyps, do they ever develop again?
Yes, so it is possible that if you develop polyps, that you can also develop polyps in the future. So I'll give you some general overall guidelines on how to treat polyps, and you don't have to remember this. If you have someone that you trust as a primary care physician or a gastroenterologist or an endoscopist, these are just terms to describe people that do things with your screening process. They have recommendations that are well defined in the literature of what to follow. But for the general population, what I would tell them is, again, know some things about your family history so that it will give you some sense to know which category you fall into. Do you have a first degree relative that has a history of colon cancer? Then you know that your risk might be slightly higher than the general population. So you have to make that distinction. Once you make that distinction, then I would say on average, about the age 66 is when most people develop colon cancer. So between the ages of 45 and 75, you have to follow some screening protocol. Now, if you're high risk, quote unquote, meaning say you have a family history of it, then the tools that you use for screening may likely involve something like a colonoscopy. But if you're average risk, meaning no family history, and you're between the ages of 45 and like about 76, then you can use other tools for screening, i.e. the stool test or the blood test. So that's how I would make that distinction for people. So you have to figure out what's my family history, and then what are the screening tools I can use. and then what age bracket am I in, so I can know how frequently. So now, if you do a screening test and the screening test is negative, say a stool test, and you don't have high risk, and then you don't have things like changes in your bowel habits or blood in your stool, which are other things to think about, then you can continue the screening process based on the recommendations given to you by your healthcare provider. Now, if you happen to have higher risk, just as some of the cases you were alluding to, then in that scenario, what will then determine what gets done next is the findings from the colonoscopy. So if a polyp is found, they usually take that polyp and put under the microscope and look at information about the polyp. All they are trying to do is sort of classify the polyp to tell us about its risk of becoming cancer. Now, if you have more features in the polyp that look risky, then they will sort of shorten the interval. That means the time between when you have this screening and the next one. So when polyps are taken out, they're put under the microscope and they're looked at to get information about what the polyps look like. And then from that information, they will then devise a plan of when your next screening will be. So in general, if the polyps don't show anything concerning, then you may fall into their screening category of something between 5 to 10 years. That's just on average. But if the polyps show something concerning, they'll shorten the interval of time where you do the screening, and you hear people do it like maybe every other year or every 3 years. So so in summary, I would say the first thing to know is what's your family history, because that will change your risk category. And then sort of your age is the other determining factor. So between the ages of 45 and 76, because as I mentioned, around age 66 is when most people get colon cancer if they'll get it. So in that age range is where you should be doing some screening. So if you're average risk, it sounds reasonable to use some of the screening tools that are non-visualized, right? Which is the blood test or the stool test. But if you're higher risk, say some family history, and then there's sometimes first degree relatives or second degree relatives, then it then becomes important that you consider other screening tools like a colonoscopy. Now, when that colonoscopy is done, they visualize. With that visualization, if polyps are found, those polyps are removed. Information from that polyp is then used to guide your next screening steps. Hopefully that makes sense.
So these polyps you're talking about, are there vitamins or diet that you can take to help fight those polyps?
Okay, good.
Are there things that are going to help increase those polyps just from your diet?
Good question. So I would say there are general correlates of things you can do to reduce your risk of colon cancer in general. Whether that directly affects polyp development, that may be harder to tease out. But ultimately, what we're trying to do is reduce the risk of colon cancer, right? So the general things that you might have heard before is red meats are things to try to reduce. Not that you don't consume any red meats, but reduce the amount of red meat. Increase consumption of vegetables, okay? Green leafy vegetables. And the other important things that are just part of overall health metrics are overall improvement in your health, means exercise, good diet, all those things matter, right? And then once you accomplish those things, those are the big things you can do to reduce your risk. Now, there are other habit things that you have to keep in mind. So little to no alcohol also helps reduce your risk. Avoiding use of tobacco products also significantly reduce your risk, because those things are well documented as risk factors for developing colon cancer. Not only colon cancer, but other cancers. Doesn't mean everyone that smokes gets colon cancer. It doesn't mean everyone that smokes gets lung cancer. But what it does mean from watching lots of population studies is that if those lifestyle things are part of the things for you, in general, it will increase your risk for developing colon cancer. So what are things you can do to prevent colon cancer? So like we talked about, exercise, having overall great health in terms of managing other things about your health, and then things like what you consume, reducing red meats, leafy vegetables, right? Some people talk about fiber. I think the data is mixed on that, but I think the general idea is then avoid other risk factors like decrease the amount of alcohol you consume, decrease tobacco use consumption. If you do those things in general, you can significantly reduce your risk. Now, you may not be able to eliminate your risk entirely, so the other way you can then reduce your risk is by adding screening, because with that screening process, polyps can be found and then those polyps can be removed. Because remember, not all polyps are cancer, but all cancer almost exclusively come from polyps. So those are all the things I would say to decrease your risk: diet, lifestyle, and then screening.
I have a question for Dr. Stevenson. Okay. Could you provide any updates with cervical cancer? At one time, I was hearing a lot of friends were getting cervical. A lot of people I know, not specific friends. And are there any updates we should be aware of as women? Some of the things we might be doing for preventive care?
Yeah, so in general, the risk of cervical cancer is decreasing. It has decreased over the years due to screening with Pap tests. One of the things I wanted to make sure that everyone was aware of, there's a difference between having an annual exam and a Pap test. Back in the day, we would usually say, I'm going to get my Pap. But the Pap test is actually just the test to screen for cervical cancer. But at your annual exam, that's where we're doing your whole history and physical. We're advising you of all the other preventative measures that need to be taken, like breast cancer screening, colon cancer screening, and then we do the Pap test if it's necessary at that visit. So depending on your age will determine whether or not you need to have the actual Pap test done. We recommend that you start screening at age 21. Over the years, it's been at many different times. You've probably heard 18 when you become sexually active, but currently right now, the guidelines state age 21. But at age 21, we recommend that you have cytology, or where you just look at the actual cells. We know that that's an acceptable screening measure for women of that age. We do know that women in that age range will be at an increased risk for HPV, but because of a young age, the thought is that you will clear it appropriately, and it will reduce the amount of unnecessary tests that are done to try to treat the HPV. But once you get past age 29 and you get between 30 and 65, we recommend that you add HPV testing. HPV is the human papilloma virus, and that virus is really what's closely associated with cervical cancer. The recommendations is to do the test with cytology every 3 to 5 years, depending on your risk. And one of the things to think about is that what is your risk? Because the risk is closely associated with your sexual practices, because HPV is spread through sex. So if you're in a monogamous relationship, one partner, you're sure of what your partner's status is, then you can probably consider yourself low risk. However, if you have an immunocompromised immune system, if you have multiple partners, or your partner has multiple partners, or you have gotten new partners, then you couldn't really consider yourself to be at low risk, so you might need to do your screening a little bit more frequently. I still have patients that come and get the test done yearly, just because of peace of mind for them, but according to the guidelines, every 3 to 5 years between that 30 to 65-year-old age range is acceptable. And then once you get past 65, if you don't have any significant risk, you can stop the screening, unless you have a history of like prior precancerous changes, like cervical dysplasia, moderate and severe, or some of the carcinoma in situ.
I have a question. My mom had cervical cancer, so with me, how often? Tell me 3 years that go to get your annual Paps. How long, so far as with my family history, should I go back and get another?
So it's still the same, because her history really doesn't impact yours. One of the big risks with family is with the exposure to a compound called DES, which was a medicine that was used back in the day for like miscarriages, and we no longer use that medicine. I think we're finally out of that time frame where most people aren't affected by that. So as long as you don't have some history of that use with your mom, then your risk should be as the general population.
Okay, so it's like 3 to 5 years?
Every 3 to 5.
Any other questions you want to answer? Let's get somebody else.
I just need to know, should we stop eating pork chop?
You should have gave it to me.
No, that's a good question I want to know.
I would say I wouldn't say you stop eating pork chops, but I would say you should measure that in moderation. There are other alternative of things you can do. I mean, life is life. Like sometimes we're gonna have to indulge in certain things that we want. We're not designed to live forever. But I will say that I would say manage that in moderation. You do it occasionally. I don't think it's going to make a dramatic difference. But if that becomes an embedded way of life, then you might have some challenges.
Thank you.
I'll get you.
What do
You had a question?
No, you didn't.
Oh, you had
Yeah, I
a
do have a question.
Go ahead, Pastor.
Yeah, Dr. Stevens. That's,
I'm Stevens.
no,
We'll be all right. We'll be all right.
over here. You know, at what at what age group does you need to stop taking your colonoscopies?
Well, so let me then classify after age 76. So what would then happen is that once you get after between the age 76 to 85, it becomes then a personal conversation between you and your provider. I have seen populations of people still develop colon cancer then, but those screening recommendations are not as steadfast. So in other words, once you get to age 76, and if there are no other risk factors or other things to concern yourself with, like you don't have some significant polyp that was just present a year ago, or you don't have change in your bowel habits, or blood in your stool, or something that's changed dramatically, I then think it becomes a conversation between you and your provider. The other thing that I will tell people to keep in mind is, and I'm not that old, but I say this with a little bit of trepidation, but you have to sort of design in your mind, how long do you think you want to live? I know that's very, it's like, that's a lot to say, but you have to design in your mind, whether it's going to be true or not, you have to say to yourself, how long do I want to live? So say, for example, you decide, I want to live till I'm 105. I'm just making up a number, right? I would then tell someone that's planning to live to 105 that even if you stop, the recommendation says stop your colonoscopy at 76, you have a lot of life left still, right? 75 or 76 to 105 is 30 years. Lots of things can happen in that time, especially when you're older. So if you want to live that long, even though the recommendation says that you don't need to anymore, odds are because you're that much older and you want to live that long, you may have to do some of those maintenance things that are required, right? If you want your car to stick around for long enough, you have to change the oil, service it, and do all those things. You just don't quit doing that stuff once it gets to year 10. So again, I think those recommendations are embedded in what the overall thought about what the end of life looks like, right? Because if you look at, I think in the US, what's the age at which most people are, the age of mortality for most people in the US, I think it's around, 70s, I think, late 70s. So some of these recommendations are embedded in some of that information. So if you're planning to live longer and want to be as healthy and functional as you can be, I wouldn't completely abandon those screening things that you're doing, because they become even more important at that time if your goal is to live longer.
What are pouches in the colon? How are they formed? Why are they formed? And how can you get rid of them?
Okay. I think what you're referring to specifically, I'll use the technical term so that if you folks ever hear it in the future, you know what it means. I think what you're referring to is diverticulosis. You don't have to remember that. Essentially what's happening is, like I described earlier, the colon is a tubular structure. And because all parts of our body need blood supply, they're basically what I call it a drape or a mesentery. All that is basically a fat pad that contains basically blood vessels that travel from the back or the center of our body through these sort of drapes to supply the colon. Now, a blood vessel, as it travels and passes through all these sort of fat pad, it has to enter the wall of the colon at a certain point. So that point of entry creates a weakness in the wall of the colon. So what happens is that, and this particularly happens in areas, so if you think about a pipe system, so I was talking about colon as a tubular structure, so think about it as a piping system. In portions of sort of a tubular structure, where you have the most pressure is where is the tightest, right? Does that make sense? So the tightest portion of a tubular structure is where there's the most pressure. So what happens is that over the course of time, and because of what we call the Western diet, that is not very significant in allowing things pass through the colon easily, i.e., red meats. So what happens is that because in the Western culture we have this diet that doesn't move through our colon easily, so stuff sitting in our colon for periods of time creates pressure in the wall of the colon. That pressure over the course of time then forces an outpouching development in those areas of entry of the blood vessel. So that's what you're describing, this outpouchings. These outpouchings happens at areas of weakness in the wall of the colon where the blood vessel penetrates. And those outpouchings develop over time due to pressure in a tubular structure or a piping system. So how do you quote unquote make it go away? Once you develop one, it's tough to make it go away. So the best strategies to prevent getting it to begin with, right? Which is why we talk about the recommendations of, that's where I would say a high fiber diet is beneficial, not necessary for the colon cancer part, but for decreasing the chance of things sitting in your colon long enough to develop these outpouchings. So diets high in fiber, low in red meats are the general recommendations, and being active are the general recommendations of things you can do to reduce the amount of time stuff just sits in that tubular structure, and then you have sort of normalcy in your bowel movements. So that's how you prevent that stuff. But once you get it, you can then do things to sort of keep a healthy lifestyle so you don't develop more, because you can develop them in all the places that the blood vessel enters the wall of the colon.
Does it matter how much you chew your food? How long you chew your food?
I would say that has benefit for other things, in terms of just how much maybe air you're swallowing. It may not directly affect your ability to prevent diverticulosis per se, but the big things that we've seen in general at the type of diets we have because of how it creates pressure in the system. So maybe not so much from food chewing.
Can we influence how often we get the screening, the colonoscopy? Because the last time I got one, he gave me a long period of time, and I didn't want to do that, and I tried to get one this year. I got to wait until the time they said I got to get it, but to me that seemed like a long time, and a lot could happen in that period of time.
Right. So I think I understand the question you're alluding to, because it sounds like what you're saying is that you may be concerned that as there's more time passing, interval passes from your last screening, the concern that something may have occurred in that time frame. And that becomes a tricky thing, right? And the reality of it is, I don't want to bring this part into the conversation, but there's part of the reality of just allocation of resources, right? So as a nation, we have to figure out how much of these can we do, because these things, they're relatively, at some point they become cost prohibitive. So I think it's important to have real conversations with your provider. If there are things you're truly concerned about, bring it to their attention. Say, for example, I tend to believe that if most people are worried, there's an inciting event that causes that. Maybe they notice some change. So instead of having the conversation about what the change that occur is, it becomes a push towards, well, I just want to get a screening. So I think it's important to have very frank conversations with your provider. If you're concerned, express the concern you have. However it shows up, maybe you ate something, I felt funny this day, I had a couple of times where I didn't feel right. Whatever the thing is that may be making you concerned, have a conversation about it. And I think that may force the provider to think, okay, we need to think about this and watch this closer. Because a lot of times there's pressure in healthcare. We're dealing with lots of patients, so we may not pay as much detail to maybe what your concerns are. So if you have a genuine concern and you want it sooner, my recommendation is that have that discussion with your provider and explain, I am worried because of this reason. I think most people and most providers, because of the way we function, we will at least take that seriously and say, this is what we need to do differently, or shorten the time of the interval. And I think that's how you can get success if you are trying to get something done sooner.
Okay, so we're kind of getting close to our end of time. So what I would like to do, I know Dr. Stevenson has a brief presentation. We're good.
Yeah.
Okay, and then Dr. Durden, I would like to know how, you, as a surgeon, how you tie into all of that with the cervical and the colon and the breast cancer and the reconstruction. How do you tie into that?
Sure. Hello? We'll switch back. So, like Dr. Opior was saying, I work with these surgeons on a daily basis in terms of them providing the care, in terms of making sure that the cancer is taken care of, in terms of them resecting that, and making a plan for the chemotherapy or radiation care that may or may not be needed. But then there's a defect when they have to do surgery. There's a scar. There's something that needs to be put back together to help patients move forward. So my part of the equation is trying to conceal or hide the scar or fix a defect or a surgical problem that has been made by taking away the cancer. For example, Dr. Obior and I have taken care of a couple of very complicated sarcomas, which is a type of soft tissue cancer that create large defects in whatever part of the body that they come, and somebody has to put that back together so patients don't get hernias or they don't have a large wound. And so he would call me and we would talk about the case, and I would rearrange tissue to cover that defect. Or with the breast surgeons, after a mastectomy, then there's the option for most women to have some type of reconstruction to try to decrease the risk or the effect of the comorbidities of them having a mastectomy. So they would call me and I would do that part of it. And for cervical cancers or vaginal cancers, it's kind of the same principle. Somebody has to repair that defect after they take out the part that needs to be taken out. So that's kind of what I do on a daily basis. Yeah.
So now I'm picturing, because my dad had throat cancer.
Correct.
And we did have a surgeon come in and
Correct.
after the throat cancer.
That would have been me.
So that's
Exactly. Yeah.
And just to add, Dr. Donning is fantastic, by the way. So let me just add some other things that he does that he didn't mention. So we talked about something along the lines of skin cancer. So if you notice, our skin has a little bit of stretch to it. Now, if someone develops a cancer on the skin surface and we have to remove it, we don't only remove where the cancer is, we have to remove some normal tissue around there, because beyond what our eyes can see, there might be microscopic cells that exist around the vicinity of where that cancer is. So as a result, what we do is that we create this space and a defect. Now, once we remove any form of tissue, it's not easy to just find another tissue to put back in, because our body wants to just remain in its natural state. So what he does is that he uses tactics or techniques about what he knows about the anatomy, just how our bodies are formed, and he moves things around such that even after we create a large size defect, on the outside, all you might see is a scar, but he does a lot of rearrangement and movement of things to create the appearance that things are closer to your old baseline. And he does that in a variety of other ways too. So not to be very visual, but people sometimes have issue when we talk about the idea of also colon cancers. There are also cancers of the anus, which is an extension of the colon coming out to the anus. Now, if people have cancers in their anus, we have to sort of remove that region, and as a result, we create a space there. Something he also does is that he finds other parts of the body where he can take tissue from, and then remove tissue from other parts of your body to place in places that we create a defect by using very special techniques. So they're very valuable, because I always joke about this with him. It's like, I just remove a bunch of things and then I just look at him. It's like, hey, you got to take care of the rest, because I don't know what you're going to do with this. That's how but his role is to help us when we remove things, is to help us sort of restore some level of normalcy, because there is a cost to removing whatever organ or portion of people's body. So his role is to help restore some decency in people's lives by sort of bringing them back closer to their sort of normal baseline.
I have one last question too. I'm sorry, because I wanted to know an update on hysterectomies, because I had a hysterectomy. I'm not even going to tell you how long ago. It's probably cured by now, but anyway. So I've heard someone talk about how they're not doing them as frequently as they used to, or is some. So could you give us, for the ladies in here, some updates about hysterectomies?
So what I think you're alluding to is probably the time frame where it seems like every time you went to the GYN, your uterus was being removed, and not really sure exactly why it was happening, but the most common cause for a hysterectomy is due to abnormal uterine bleeding and or fibroids. Fibroids are the benign tumors that occur in the uterus, and most of the time they're either large in size or they're multiple throughout the uterus. And so that's one of the most common reasons why we would take the uterus out. When you have a hysterectomy, it's actually removing the uterus and the cervix. Usually we would try to leave the ovaries and the fallopian tubes to prevent you from going into menopause. Back in the earlier years, sometimes they would take everything, and most women would end up in menopause at age 30 or 35, depending on when they had everything removed. But as of now, we try not to take the ovaries and tubes unless it's absolutely necessary. If you're close to menopause, then we will often suggest removal to decrease the risk of ovarian cancer. We know that there's not really an acceptable screening test for ovarian cancer, so usually when it's diagnosed in a very late stage. So if you're closer to the average age of menopause, which is around 51 and a half years, then we do suggest that you remove them. But other than that, it's up to you. There's many different ways to treat the abnormal bleeding and fibroids. You can try medical management with like hormones or birth control pills or things like that are used. You can try removing individual fibroids depending on the size of them. There's non-invasive procedures like uterine fibroid embolization, where they go in and block the blood flow to the uterus to help with the pain and the bleeding. And then last case scenario would be to take the entire uterus out. So I would say that in general, probably the amount of hysterectomies have decreased some compared to the earlier years, and we're not so quick to take the uterus out like it used to be.
I have another question about that.
Okay.
What is the cause of a prolapsed uterus?
Laxity of the tissue. As you start aging, you lose the ovarian hormones. Your ovaries make estrogen, progesterone, and testosterone, and when you start losing the estrogen, you get a laxity in that tissue. You'll start seeing the bladder start to prolapse, the rectum can push up, just all of that vaginal tissue can start just dropping. And also, if you have a hysterectomy, if they don't do some type of tacking procedure, then you can get a prolapse in the tissue.
Okay, this question is for Dr. Durden, and also you all can chime in as well. But since you are the one who moves things around, regardless of what the situation is, so is there anything from a preventative standpoint you would recommend, you know, just in a general sense, what we can do for ourselves that would put us in the best position if we had to have surgery or things like that, that we can do that would be able to help you, help us, and help you all have a better outcome?
Can I say one for Dr. Durden? Don't smoke. Don't smoke.
Yeah, so it's similar to what Dr. Obior was saying earlier about general overall health. Definitively smoking, we know that greatly increases your risk of having a healing problem because it causes microvascular circulation collapse, meaning that the small blood vessels that go to this tissue doesn't have enough carriage of blood to make it live, which is huge for us to try to get healing. Which is huge to us trying to get you to heal. So smoking is one. And you know, around the hospital, they laughed at me for a couple of years. They still pick at me, but I got this long list of things that I'm like asking patients to do. You know, stop smoking. I think that's very important. So we test for that now. Try to get some control over your glucose. Usually we didn't check on hemoglobin A1C. Now we test for that. Don't give the patient a bunch of sugar in the hospital. You know, when you walk in a room and the patient from the hospital staff, they got, you know, 2 sodas, a jelly, you know, a cookie, and, you know, something with heavy white bread in it. You're like, hey, they're with us and they got this from us. So we can definitely give them a healthier option while they're in the hospital. Don't put all of their medications in D5, which is a type of IV solution. Don't give them random sugar. Kind of think about what you're doing, and so that's definitely big. Cutting down on overall weight is always good. Why? Because again, it's going to help us control your sugar. Also, it creates less. So the thickness of tissue I have to move matters. So the higher the fat content of the tissue, the less blood supply, because fat doesn't get great blood supply. Muscle does, and dermis, your skin, that's where the blood supply is. The fat does not come with blood supply, so it's harder to get that to heal when you got to move it to other parts of the body. So I would say those are my kind of big things: overall health, and kind of concentrating on the things we can change, because some of it we can't. What we have to deal with, the location, we can't change that, but we can get in pretty good health. All of my patients, I make them take protein supplements, because everybody is malnutritioned. Nobody eats a good diet. Absolutely nobody. So everybody comes in malnutritioned. So bumping their vitamin intake and protein intake before and after surgery is huge to trying to get them to heal. And if you really think about it, every time we go to surgery, we starve people for at least 2 days. Day before and day after. The day before, day of, and usually a little bit of the day after. So if you think about it, you're getting ready, you're going in to run a marathon. It's a marathon, you're gonna lose blood, you're gonna be under stress, and we starve you for 3 days around that. And so getting someone to come in a hyper protein state is crucial to kind of getting through that. And the last thing they really fuss at me about is the room temperature. Patients have surgery and you go in a room and the room is like 60 degrees, right? And so they're under the cover, the room is 60 degrees. And I always ask them, what happens when your room is cold like that? They're like, oh, my skin turns pale. And I like, well, that's what I don't want happening while we're trying to get this to heal. So we want to keep it kind of like you would a baby's room. Like you want to stay in an environment where you're perfusing or providing blood supply to your skin, not making everything shut down. But those are the kind of things I would start with.
One more question.
Good morning.
Good morning.
There's right now the collagen supplements and collagen things are really hot on the market.
Yeah.
And I do take a collagen supplement. I want to get your opinions on are there really any benefits to that or what?
Yeah, I think we got a better answer.
Absolutely. Definitely recommend taking collagen. As you age, you start to lose a good percentage of your collagen with about 2% or so every year. So I would recommend that you take a collagen supplement, increasing the protein, as Dr. Durden said. There's some other options out there, essential amino acids to help building muscle as well, different things that we don't think about, but the biggest issue is losing the muscle as we age, and all of those things can help increase that for the healing that Dr. Durden said after surgery, but also just in your general life. I liked your marathon analogy. He knows I'm a marathon runner, but one of the biggest things I do after I run is to drink a protein shake, because after you break down all of the muscle with the pounding on the pavement, you want to try to begin to repair it back by increasing the protein.
And I have a question. When you're doing your mammograms, when they send you something saying you have dense tissue in your breast, what does that mean?
I can comment. Can you hear me?
Yeah.
Yeah. So what that does is that basically think about mammogram as an X-ray. So it's just basically a fancy X-ray looking at the breast. So what that's telling us is just the texture of the breast tissue, and that density might have the chance of obscuring things. So if you think about something that's a little bit more dense as compared to things that are less dense, more dense things might obscure sort of underlying findings. So that information is just a way to tell you that, okay, you might have breast tissue that has the chance of maybe obscuring more things. It doesn't necessarily translate that you have to have alarm. It just means that once there's some awareness of that, if there's a suspicious finding, then they may do other things to help figure out, should we worry about this or not? So the more dense breast tissue is, the more likely, like, if there's something underlying, you may want to investigate more.
So should you, if you have dense breasts, when you get a mammogram, when you have dense breasts, when you get a mammogram, should you get a mammogram and an extra, or how should that be done?
Right. So the way I would say I would recommend for people to approach that is, I think the evolution of our screening tools have improved significantly. No matter what screening tool we have, it's not going to be perfect. So if there's just something you're worried, again, like if there's something you're worried about, you feel a mass or a lump, just discuss that with your provider. That being said, even if someone has dense breasts, I would say that there are general recommendations of what to do for breast cancer screening based on your age, based on discussion with your provider. Now, if there then becomes a finding with one of your screenings, there are recommendations of what to do next. So it doesn't mean that what you do at the initial screening should be different. It just means that if something's discovered with one of your screenings, there is a chance that if you have more dense breast, you may have to do more things to clarify what that finding is. So with a dense breast, it just likely means that if there is a finding, it doesn't mean a dense breast gives you a finding. If you have dense breast and there is a finding, you may require additional tests to clarify what that finding is. So that's how I would approach that.
In most, I guess it's case by case.
Yes, it's case by case, but the standard mammograms we're doing now is screening based on all your risk profile. That's usually sufficient. Now, even if you have dense breast, what I'm saying is that when those mammograms are done and you just happen to have dense breast also, if there's a finding, then there's more investigation that needs to be done. So it doesn't change what you're doing now for screening. It's just an awareness for you to know if you see that finding, that if they see something, they may ask you to do more tests. That's why some people will go, they'll do a mammogram, then it's like, just come back next year. But some people go to do a mammogram, we just kind of don't like what we see. What that means, it doesn't mean that you necessarily have cancer. It just means that we are unsure, that we need more stuff to clarify what's present.
And usually that test is going to be something like an ultrasound,
Right.
because the ultrasound is able to look at that tissue a little bit better. So if we have a patient that has a breast finding, a mass or something, and they're under the age of 40 and or younger, then usually we'll recommend an ultrasound first to look at that, and then proceed with more extensive testing if needed, because we know that their breasts are going to be dense. Also, if you're taking hormones, it's more likely that when you go get that mammogram, you're going to have that finding that comes up, because they're not used to seeing a denser breast in an older woman.
Oh, okay, because mine comes up like that. They'll send it, and it'll say dense each time.
Right, so yeah, it's not a thing to be alarmed by, it's just having that understanding, just like she mentioned. I think it's more common with, I use the word loosely, younger women, but in younger women, there's more chances of having dense breast. As aging happens, the breast becomes less dense, but that finding in itself is not alarming. It's just an awareness that it may, if something comes up, it may require just more testing, just like she said, an ultrasound.
Okay.
Dense the same as lumpy?
Not necessarily, no. Not the same thing.
One more question, and then we're gonna wrap up with the panel.
I was in that category. I am a double breast cancer survivor, and when it was discovered, it was very small, and then when I was having the sonograms done, I explained to the tech that something felt strange on the left, and she says, well, you have to talk to the doctor, because you have to. I've already talked to her, and I thought that it had been okay to do both breasts. And so after doing surgery the first time, a couple of weeks later, they didn't discover that I have to go back in because I have cancer in the other breast. And mine are dense breasts, but what I want to ask is it paranoia when you go through this, that your breasts, number one, are so different because I did not have them removed, Because of the surgery, you have so much scar tissue, and so it's just different. And my life will always be different. But when I feel sometimes it's a lot of pain, and I'm still told that your nerve endings are still awakening, is that something that lasts for years? Or is it something that you just really should learn to live with and ignore it instead of being concerned about it? That's what I'm asking.
Fair enough. I'm sorry you had to go through that. That had to be probably a challenging time in your life. I hope you had the right support during that time. Cancer diagnoses are very challenging, and I'm sorry you had to deal with some of that. What I usually share with patients is, or just anyone in general, is it's a very challenging process, and I know some things don't have an easy fix. And when someone has a unique circumstance, it's tough to sort of, measure everything accurately. So there are just some faults in the system. And as a provider, on behalf of all of us, I say that we can do a better job. We may not be perfect, but I think part of it is I also encourage people to figure out the right way to be advocates for themselves. So there are just some challenges in general. So you meet a provider, you give your complaints. Some things may get lost in translation because we're not perfect. We make mistakes all the time. And then you express a concern and that gets missed, and then or not articulated in a way that's understood, and then you're assuming things will happen. Unfortunately, yes, you sort of have to revisit that idea. It's like, I don't like what I feel here. I might have communicated that. Maybe I don't remember. Maybe I did. There are lots of variables of how that could go down. I usually encourage people, it's like, if you're worried or concerned about something and it's not addressed, it's fair game, especially with us providers, because we know we are not perfect. It's fair game to revisit that and say, I don't like this concern, let's address it. Now, to answer the question about the pain, I'm very gentle when I say this, but I'm saying this from just accumulation of experience. It's not that things like breast cancer never cause pain. It's that the overwhelming majority of breast cancers don't come with pain at all. So let me repeat that. Doesn't mean breast cancer never causes pain. It's just that the overwhelming majority of all the breast cancers usually don't have any pain signal that come along with it. So I generally encourage people that pain in itself, and I'm saying this very gently, I think a lot of times in just general sort of idea about life, if I wasn't on this side of the equation and I wasn't a provider, I don't know all the things I know, I would probably have the same thought process, equating pain with cancer. It doesn't quite work in that very direct correlated sense. So pain usually comes from, truly, yes, nerve endings that are irritated in some form, right? That's just a general idea, right? So, but it doesn't mean, again, like I said very specifically, but it doesn't mean cancers can cause pain. It just means that they're not directly correlated all the time. So how do you navigate the issue with the pain? I think that becomes challenging. One is, yes, it's tough to deal with a problem that's constant all the time or annoying. You might have to use a myriad of techniques, massages. You might use other techniques like using what we call anti-inflammatory drugs to a limited extent, because those things have pros and cons. You can use techniques of cooling. You can use techniques of sort of relaxation, maybe non-conventional, non-medicinal techniques to sort of reduce the discomfort. And for better or for worse, which is why we were talking about this, is when we manipulate tissue, even if on the outside it looks the same, there's some changes that may be permanent. And that is really tough to go back and reverse. And there's some people that truly experience that. So I'm being gentle when I say this, is that it's finding sort of coping strategies to deal with the thing that now there's no easy fix for. So I would say that's how I would approach that, is the pain may not necessarily be a signal for, say, recurrence. whoever your provider is probably has some strategy of how they help manage your surveillance, because there's surveillance things they have to do after you get treatment, and those surveillance things should remain in place. And any concern you have, no matter how small you think it is, if you're concerned about something, I think bring it up to the awareness of the provider, and that should be addressed appropriately. You sort of have to be an advocate for yourself because you just know yourself better. Now, what the provider's role has to be is like, interpret what you're giving them as information and try to figure out what the surveillance and clues that come from that is to help say, okay, we're addressing this particular issue. So as far as the pain you're experiencing, I would say you might have to use some of these sort of conventional techniques to sort of manage that over the course of time.
So two other things I would add to what Dr. Obiora was saying is, one, the advocate part. For me and for my family, we've had to do it too. And anytime you feel uncomfortable with something, say stop. Say, hey, I thought y'all were gonna do both sides. And if they say I can't or I won't, say, okay, let's stop. Let's go get the doctor and let me clear that up before we go. Just say stop. Say, okay, let's stop. I thought something else was gonna happen. Let me go back and talk to them and clarify that, then we can do this test. That way, you know, in our particular instance, it was a similar thing to where my wife had a lesion on one breast and something that was questionable on the other one. We wanted both of them tested, and they were kind of like, well, no, this is the one we need to address. So it's like, no, let's stop. Let's go back and talk about it again, because we would like both of them to be examined, or to know why you're not going to do both. So just say stop. Don't feel embarrassed about it. Don't feel shy about it. Don't feel any kind of way about it. Just say stop. I thought something else was going to happen. I want to know why they're not going to do this, or more information on it. So that would be my advice. And you just say it as plainly as that. And then in terms of the pain, what we often know about surgery is that it is going to cause a scar. There's going to be pain. It is a consistent, lifelong process of managing it. It has a start early on, afterwards, and continue. And that is massage, stretch, and manipulation to keep the scar tissue stretched out as much as you can. That is heightened if they use radiation, which they use in lumpectomies or partial mastectomies each time. Radiation increases the amount of scarring that you're going to go through. So you have to have those therapies ongoing, which is why occupational therapy should be a part of the care after surgery, increasingly so if radiation is involved in that. So that's the first start. That's the daily maintenance of teaching you how to stretch, go through your range of motion, and massage that area. The second thing is that some things are not resolved with medications, anti-inflammatories, or therapy, or massage therapy. For those patients, we involve a pain specialist. We have patients that have pain that is severe enough to give them daily discomfort that is not resolved with conservative measures, to which we then talk about, can we block a nerve to this area to make it numb, or can we give some type of medication that will make this bearable? So I wouldn't say just deal with it. I would say perhaps the next step is to see a pain specialist to say, hey, is there any way we can just numb this area so I don't feel it at all, or something along those lines. So things are developing, and there are other therapies for pain that I want to see somebody about pain, or I want to see an occupational therapist, or if you don't like the scar or the way that it looks, then I want to see a plastic surgeon to see if this can be changed. You know, so those are the things that I would tell you.
One last question.
Sorry about that. Henry Mason, and so I definitely want to thank you guys. It's been phenomenal information. I think Dr. Durden, you just talked on something that is particularly interesting in our environment, in our society, and where we are here, which is where we're talking about the disparities in healthcare and what that really looks like. And you just made a beautiful point when you said, because to me, you're the surgeon, and you're having to tell someone, hey, I want to check both. But we don't know that. We don't even know to ask that question. So just kind of getting a feel from you, two things, one from the panel as well. One, just if you could just touch on just some of the disparities you've seen in cancer. And two, as people who don't know, I'm in hospice. And one of the things that I see, particularly with health disparities and health equity, is that it seems like in our community, we're kind of chemo to a point of no return, right? Is that something that you would say is on the medical field, or is it something that you would say is on the families of the patients who are just unwilling to let go? And when do we need to be having these conversations so that when they do get to a certain point, they get a nice, comfortable life versus 2 weeks after the chemo and everything gets just kind of wiped away?
We're racing, but I want to jump in and I'm gonna let you take it.
Yeah, so,
let me jump in
yeah,
and you
yeah,
take
yeah.
it. Okay, fair enough. So disparities, we know that in just about every situation, us present later and a worser diagnosis than other populations. That's why when they're talking about these screening guidelines and when things should be done, that's why it's so important. Because we present late at a later diagnosis, we often have limited options for treatment and require larger adjuvant chemotherapy radiation treatments than other populations. So that is something that we can improve on in terms of our overall health and when we go to the doctor to say something is wrong. So that's the first thing. And so two things I wanted to say before we left is that the two of the common things that we always see are when skin cancers present, because we don't think that we can get skin cancer because we have melanin. So that is something I would tell you that we need to harp on in terms of if you see something that hasn't gone away, go see somebody about it and take care of that in terms of trying to get in and get earlier diagnosis. And the second one is male breast cancers, which we don't think exist, and it absolutely does. And so that functions into a lot of the disparities. There are some disparities that are outside of our control, such that for example, in breast cancer and breast cancer reconstruction, we understand that African American women are given the opportunity to have reconstruction at a lower rate than other populations, and that's because of doctor prejudice or ignorance as to just offering the therapy to them. That translates into pain tolerance, pain treatment, and other areas too. But the first determinant of how well we can navigate this problem of cancer together is how fast can we get you to come in with an earlier diagnosis. And if you take out most things from the review of these things, the thing that makes us more likely to have a problem or need chemotherapy or not be cured is that we present at a later stage in the diagnosis than other people, because we don't go and get screenings or demand that screenings are done, whether that be regionally because you don't live close enough to get to a hospital, or whether that be financially because you don't have insurance that allows you to go to a hospital to get it done. That's kind of the first part. All right, go.
I just have one thing about advocating for yourself. It's definitely important to advocate and to make sure that you get your questions answered at your visit. And if you feel like they're not being answered, to get the second opinion, or like Dr. Durden said, say stop. I don't understand this. Can you explain it to me again? Because it's really our job to make sure that you understand what the next step is. And there's plenty of times that patients walk out of the room and they have no idea. I used to deal with it with my dad. I would ask him, what did the doctor say? And he could never tell me what the doctor says. So one of the things I make a great effort to do is to make sure that you understand what we diagnose you with, what the plan of care is, when you're coming back, all of those different things, so that you can't walk out and say that you didn't know. But the other thing that I see, particularly when I'm dealing with pregnant patients, is that although there are disparities in care, when you do come in contact with a doctor who is trying to help you, please understand that and realize that and allow us to help you, because there are so many times I encounter patients where everything that I say is being met with resistance, as if I got up that morning to see how I could hurt you. So understand that there are many providers who want to help you, and that when you come in and we're met with such resistance, if we look like you, we may try a little bit harder to break that barrier down. But if we don't look like you, then the attitude may be, well, okay, they don't want it, and they just move on to the next patient. So there are a lot of disparities, but I think in the community as well, we could do a better job with helping the provider. And if you don't feel comfortable with your provider and you have the option, then seek another one, because there are lots of us out here, and you can find somebody who really cares and wants to help you.
Okay.
Yeah, I'll put one final touch. I'll try to keep this short and brief. I think everything they said is accurate. By every metric, we're African Americans or black folks, we're behind on a lot of metrics. So we just have to be frank and honest about that. So important things. If you forget nothing today, remember, you have to advocate for yourself. Just advocate for yourself. Your question doesn't have to be like intelligent or smart. Just like, I don't get this, break this down for me. What am I facing? What are my options? And like she said, maybe we have to work on some of our resistance. I think historically this comes from true places, distrust of the healthcare system. So I do get that part, but I think it's important for us to ask questions, advocate for ourselves, and then allow, like the other thing I think is important for our communities to recognize that these tools or these screening approaches that we need to do, like for our sake, we just need to do them more efficiently and get to them as soon as we can. Yes, there are real challenges about socioeconomics that are just part of the nature, and I think we can't neglect that. So that's why there's a larger conversation in society of how do we reduce the barriers of entry for people seeking care. But from the things that we can personally do is advocate, try to do things based on the recommendations and early, because most of the time, really like he mentioned, is like if we get things early, your options, not only is that we have chance of making the problem go away, you have more options. And those options will give you situations where you can get to say, okay, these are my true options, and then these are things I can do, and you can make a choice of what works best for you. So try to get in early, try to advocate for yourself as much as possible, and really cooperate with the provider. And if one's not cooperating with what you want, you can find another. So that I would say is a generous summary.
I just want to say thank everyone for coming. Thank you, especially the doctors, Dr. Durden, Dr. Stevenson, and Dr. Obior for coming out and giving us some very informative information. If you have any more questions or need some information, everything is here on the table concerning cancer awareness, hospice, and everything else. Thank you guys for coming. Thank the panel very much. Very informative information. Thank you guys. Thank you. I appreciate it.
They want to make sure that if you could, please go to the fire truck. They said no one's going. They want to make sure they come back next year. So if we could, just go say hey for a second.
And we're going to be getting together in a few minutes for our brain health and stress management panel with Dr. Jalinda Clark and but thank you. That was very informative. I was asking about the prolapse. Because I just recently I have to have a colonoscopy too, which I'm scared of. Very scared. My first one. So I'm one of the ones that push it. Thank you so much. You're welcome. Thank you. But I appreciate y'all coming.